welcome everyone. Thanks for spending some time with us this evening to talk about the Snohomish County Town Hall. This is for the residential treatment facility, and we appreciate you taking some time on this beautiful day to talk about this with your community. My name is Angie Thompson. My role in the meeting tonight is as the facilitator. I am not part of the design team or the project team, but I'm about the process to make it so that you all have an opportunity to ask questions and get questions answered and make comments and just sort of make that process run smoothly. I do want to let you know that the audio of the meeting is being recorded just in order to accurately capture issues, action items that might come up. I want to let you know that that recording could be requested as part of the Washington Public Records Act, but it'll be part of the public record. I just want to make sure that folks know about that.
Yes, so it's not going to be posted as a matter of course, we'll have to ask for it.
So I don't know that it will be automatically posted. Steve?
If the quality of it is good for us to post, we will certainly post it on the external facing page. But if we don't, you're welcome to request a recording copy of that recording, regardless of the quality.
Would it be a copy of the recording or would it be a text?
We would provide a text copy if someone needed an accommodation for it and they were not able to, listen to an audio recording. So it's really preference of the request.
Thanks, Steve. Before we jump in, I want to let people know if you haven't been in this room before, there are restrooms, men's and women's restrooms down this hallway. There's an exit this way, an exit here, and an exit in the back. There are also some cookies and coffee and cold water, which is maybe most relevant today, in the back, if any of those things are interested. Okay, tonight, our agenda, we're going to start with some logistics and some introductions, and then we'll have a few opening remarks from Dr. Carrie Waterman, the state's Behavioral Health Director. And then following that, the rest of the meeting is set aside for questions, answers, and comments. It's important that you know that this is not a public hearing, right? So this is not part of an official public comment. So anything that we talk about today isn't like an official part of a record. Though the meeting is being recorded, and it just will be listened. So the intent really of our time together is to make space for people to share comments. When possible, we're going to answer questions in real time, though there may be some need to do follow-up if questions are maybe a little bit more specific or detailed. There might need to be some follow-up from the staff. If we aren't able to get to all the questions tonight, and there's a bowl with cards in it, so we see if we can, hopefully we can get to everyone's questions. If we aren't able to, then we invite you to write your questions down, and a member of the staff will follow up with you after if we aren't able to get to all questions. Okay. After the meeting, you may see some updates to the FAQ. You'll probably have a copy of the FAQ in your hand, but following the meeting, based on some of the questions, there may be some updates there. Oh, sorry, frequently asked questions. Sorry about that. Thank you. And so if you haven't signed up for the mailing list, you want to make sure you get an update to those frequently asked questions, you can sign up for that and do that in that. And then you'll get an alert from that. All right. Comment session. Let's talk about how the comment session is going to work. If you'd like to speak or ask a question, hopefully you wrote your name down on an index card. If you didn't, you can still do that, it's fine. And you can drop it in that pool. When the presentation is complete and we move into the question and answer session, I'm going to pull 3 names out of that, just kind of randomly drop 3 names out of that hat, if you will. And we're going to have folks kind of queued up here. And then we'll have folks ask their question or make their comment. And I'll keep drawing names so that we have a 3-person queue, so that we can, make it as efficient as possible for people who are ready to come up to speak when the next person is, when the person before is done speaking. We do have some mics here, since it's a shared microphone, and we're Figuring out how to handle all these things with in-person meetings and microphones, so if you'd like, you can wipe down the microphones before you speak, just to do a little sample. Let's see, each person has 2 minutes of airtime to make comments, ask questions, and we'll keep a record on this timer here. DN stands for down, as opposed to up. Actually, it's not relevant, but people have asked that question. So we'll keep track of that, and then at 30 seconds, I'll give you a reminder that you've got about 30 seconds and we need to wrap things up. Everybody will have a chance. All the folks who have their names on the card, we'll go through everybody and give them 2 minutes, have an opportunity for answer. And then when we're done with everyone who's put their name on the list, I'll see if there's anyone else in the room who hasn't had a chance to speak. And if we still have time, who hasn't had a chance to speak, we'll give them a chance. And then if we've gone through everyone the first time who wants to speak and we still have time, then folks can come back for those second cards. The cards are back at that sign-in table. Oh, where do you put them? In the bowl. Yeah, in the bowl. Oh, and they're going to bring the bowl up here somewhere with the bowl. And then I have another one when you're ready. Okay. So, let me just look here. Everybody's anxious to see. All right. I think that covers the logistics. I'll remind everybody about as we jump into the comment session. But I'd like us to jump in. I want to have as much time as possible for the Q&A. So let's get started. I think Dr. Carrie Waterman wanted to make a few opening remarks. Dr. Waterman is the director of the State Behavioral Health Authority. And so I'll turn it over to you.
Thank you. Hey, good evening, everybody. I just wanted to first say thank you all for taking time out of your schedules to be here. It really is appreciated, and I just wanted to let folks know we are here to talk about the healthcare facility that's open in Snohomish that will be focused on mental health treatment specifically for community members in the state of Snohomish County. Really wanting to have everybody know that even though we may not have time to answer all of the questions tonight, we will be doing our best to make sure that we can answer those questions. I know that there were folks here the first time around. There was a town hall, and that we are trying this different format to make sure that we can hear more voices and give an opportunity for more folks to share their feedback. So really just wanted to extend from me to all of you. Thank you so much for taking time out of your schedules to come here and be here with us tonight. Thank you.
Thank you so much, Dr. Warland. I want to transition, actually we're ready now to transition into the question and answer session, but I want to give a couple introductions so you know who's on the panel here. Let's see, I'm going to start here on the left, my left. So let's start first with Lou McDermott. Lou is the Deputy Director of Healthcare Authority. Next, we have Dr. Teresa Patinos, the Director of Washington State Medicaid Program. You've already met Dr. Waterland. Next, we have Keith Baines. Keith is a consultant representing the Tulalip tribes. We have Evan Haynes, Pre-Construction Manager for Corsville Construction. You guys just raise your hand. Nobody can see your cards. I can't see them. I can see you. Jim Walsh, Architect for BCRA, and Justin Barreau, Engineer at BCRA. Also in the audience, we have Amber Leaders, the Senior Policy Advisor to Governor Inslee on behavioral health. Amber's here in yellow. And Dr. Brian Rieblinger. Oh, you're here, yay! Traffic was bad, yeah, sorry about that. Chief Medical Officer of DSHS Behavioral Health Administration. So those are some of the folks who are here who can get your questions. Okay. Look at you're ready with the bowl here. All right, so we have some. I'm going to tell you, this is like, it doesn't matter how old you are, picking something out of a hat like this is all right, so what I'm going to do is call the first 3 names of folks, and as we come up, that way you can come to the microphone and you can ask your question. So All right, so we have, Peggy Mike? Is that right? Did I get it right? Okay, so let me call 3 people so we all know who's in the queue. Brent, is it Cops? Coos. That's it, don't have to, sorry about that. So Brent, you can get in line next, and then last one. Hank Tingler. It feels like you wanna lie, right? All right, so let me pull these so I can get in order. All right, so, sorry? Yeah, okay, because your questions on that, great. You hold on that. Okay, so Steve is in charge of the timer. He's gonna get it started, and let's figure this out together. Here we go. Go for it, please.
My question is about staffing levels, and how are you going to be able to guarantee qualified staff? President Permanente right now is trying to hire,
Hold on. No, it's probably right. Hold on. Okay, no, you're, I was in the middle. All right, try again.
is that better?
You guys hear?
No.
That sounds better. I don't know. Okay.
My
Sorry.
question is about the staffing levels. There just was a thing on the radio about President Permanente not being able to hire healthcare workers, and how are you going to guarantee that you actually are able to keep your staff and maintain the staff the whole time?
Okay, so that question's on staffing. Can you folks hear in the back?
No.
Okay, so that question was around retaining staff. So. Yeah.
Man, the microphone situation.
Yay! All right, excellent. So, Deputy Lee, my name is Tina, as mentioned, I'm the Medicaid Director. I'm also a family medicine.
So you just get it closer to your face.
Yeah, you hear me now? How about this?
No.
Project.
Can you hear me now? Yes. All right. Good evening. My name is Teresa Patinos. I am the Medicaid Director. I'm a family medicine and addiction medicine physician. The question was about staffing. It's an excellent question. I'm sure you've all heard that staffing is a challenge everywhere. In hospitals, in counseling facilities, in daycares, in nursing homes. We're in an unparalleled time. The pandemic has done a lot of things to a lot of people, one of which has made a lot of folks reconsider where and how they want to work. What I can say is from a healthcare facility perspective, we are not going to admit patients unless there is adequate staffing to take care of them. This is a healthcare facility where people are admitted because they are ill. They're ill from a behavioral health condition, they are ready to get better. And in order to do that, we need to make sure they're safe and have adequate treatment. So unless we can adequately staff both for safety of the patients and the staff and provide them the kind of care they need, we would be irresponsible to open. I don't know what the years will show, because that's what we're talking about opening it. A lot of changes in the last few years, a lot more is likely to change. So I think that's a valid question. And I think time will give us more information about who will work, who won't work. And the onus is on us as the contractor and the people who will be running the facility to ensure that they have the tools to attract qualified staff. This is the Department of Health's responsibility to make sure those qualified staff are appropriately licensed and credentialed. And it will be the responsibility of the agency who runs that healthcare facility to ensure that quality care is provided. And we have a role in that as well.
Thank you. Okay, I'm gonna call the next person who will come to the back of the line here. We've got Jim Bloss. So Brent, you go ahead, and Jim, you're the next one. There's a baseball card for that, right? Like in the, what's the
On that.
On that. On that. Okay, thank you.
Hey, well, thanks for being here. This is important, at least to the residents of this area. Live close by this proposed facility. And I think I can speak for many here that the main concern for us is security. We are a rural community here. We are spread out. We don't have a lot of resources. In the news lately, this comes to mind. There was an individual in Seattle who was attacking people, stabbing people. He was brought in front of the court system and determined to be not eligible for addressing the court system. And he was deferred to Washington State Hospital Court. He has since not been found a place to stay. He was given pocket money, I guess, to enable him to live off the community as such. In the handout today, I'm sorry, I don't know the individual's name. It's been in the news for quite some time, last month or so. But here in the handout we were given, it says, these individuals are not involved in the criminal court system. This individual was determined not to be appropriate for the criminal court system. Is he the kind of individual that we're going to find in a facility like this? And that's, thank you.
Thank you. Okay, so that question is around the type of individuals that you serve with.
I'm going to start this, and then I'm going to ask Dr. Wavenger to add anything that I like. The types of patients that will be in this facility are folks who are not involved in the justice system. They will not have committed a crime. They will not have committed a crime that will lead them to question whether or not they are going to be competent to stand trial. This is a facility for people who have schizophrenia, for people who have bipolar disorder. They do not commit a crime. These are the folks that you may see out in Seattle. If you come to Seattle, you see these folks curled up on the street or wildly gesticulating because they don't have their behavioral health condition managed. These are not people who commit crimes. These are folks who need to be put on the right medications, given the right support, given the right rehabilitation, so that they can comfortably live among the rest of us. For the most part, these are folks who are frightened. Their civil liberties are taken away by the court when they're put in here for 90 or 180 days, and they don't know anything because they don't necessarily get visitors. So these are not the folks who are involved in the criminal justice system. That is a completely separate forensic pathway. And Dr. Wakefield, I don't know if you want to add two more comments to that.
I can give you a microphone if you want to add.
Sure. Can you hear me?
Yes.
So, as you know, many of our clients or patients in the mental health system may have had some connection with law enforcement, as many of us have along the way. That is not. You may disagree with me, but a significant portion of our population has been in jail, prison, etc. So we can't guarantee that these individuals may or may not have some connection to them. That is not the focus of what's going on here. This is exactly what Dr. Martinez talked about. It's focused on getting them treated for mental illness, getting them well enough to return to some semblance of a normal life, potentially go out to work, get a place to stay, live, and stay out of these facilities. The goal is that they will not come back. And ultimately, what we're trying to do is give them a life that are in a meaningful way of living, taking care of themselves. So that's the goal.
Thank you. We have Hank and Jim, and then following Jim, we have Beth Bryant. Next. Take your time. Hank, go ahead.
I just want to echo my neighbor's thanks for coming out and doing this. We appreciate it. And hopefully we're going to answer some hard questions here. For example, Doc, can you put it in writing that those are the patients, the only patients we will see at this facility? And I ask that question because I've seen documents that question, what are you going to do with the empty beds in this facility if you don't fill it up with 90 or 180 day patients? There was talk of 120 days or just short-term patients as opposed to the 90 or 180 days. Will you put that in writing as part of the conditional use permit?
So this question, for those of you who may not have been able to hear, is around what guarantees there are about the type of patients that will be here, that will be in this facility.
So first off, Could I put in writing with any sincerity as a person to say something would never happen? I can't do it. I don't think anyone in this room can do that. That said, can we say that the focus of this facility is for people who have a civil commitment? Now, maybe they have had a ticket at 16 before they developed their schizophrenia and their first psychotic break. That's an interaction with the law enforcement system, so they may. So I can't say you don't get to see people without records. So for me to say absolutely never will there ever be, that's just not realistic. That said, the intention of this facility is for people who are civilly committed. They cannot take care of themselves, and they need to be stabilized and supported as they can.
We understand it's for a civil commitment. We also don't really count traffic tickets. We're talking jail time for people who have committed criminal acts in the past. So again, will you say that, first off, they're not going to come into the facility because they committed a crime, because they're a civil conversion?
So they're not necessarily civil conversions. What I will say is, what I find sad as a physician is that because we don't always understand things, myself included, before I had a brother that developed serious mental illness, or a cousin who developed serious mental illness, and died at the age of 20. We don't understand that which we don't know. We have made it a crime for people who are unrest and talking to a wall, because that's scary. We're not used to that. When that person thinks that that wall is going to eat them, and if they don't take all their clothes off, the world's going to go on. We've made that crime, those folks go to jail. So can I tell you that someone who has that type of crime, or who made a broken window because they think they're getting close and a monster is going to eat them? No, I can't say that those folks won't be there, but I can say those folks will be helped by doing that.
Isn't one of the criteria for admittance into this facility that they pose a threat to themselves, potentially to others or others' property, or be gravely impaired?
That is the language of the law, and grave impairment means that they can't figure out how to get food for themselves.
I understand what grave impairment means. Do you understand what potential for harm means?
I do understand that, and what I can say about that is, if you include anxiety and depression, 1 in 5 people have some diagnosis of a mental illness. 1 in 5 people have a diagnosis of a mental illness. If you look at all the crimes committed across the population, 4% of those crimes are committed by people with mental illness. People with mental illness are much more likely to be victimized. They're much more likely to be sexually assaulted, physically assaulted, robbed, and taken advantage of. So there is that.
We have no objections with having those sorts of people. If that happens, ones that are gravely disabled or just laying in the corner. Okay, we're talking about people that have been violent or have the potential to be violent.
Without the ability to know someone's history and see how they act when they are unstable in mental health crisis, it would be completely disingenuous for me to promise something that I can't.
So in other words, this facility could morph to a short-term stay.
No, that is not the intent of this facility. And I'm going to ask Dr. Waterman to respond to that. It's not the intent.
Is it easier if I stand up to
Yeah.
go? Okay, thank you. My foot is turned around and curled under my seat, excuse me. So, I understand exactly what you're saying. There are a couple different tracks, and I'm not going to go into all of the detail around all of the different ways that folks could enter the system. Long story short, individuals who are here may have had 911 called, and in a case like this, they may have something that's called a designated crisis responder come and reply and do an evaluation, a civil commitment evaluation. And I think, Hank, what you're talking about is, are we going to have individuals coming into this facility who've been arrested and maybe the judge has ordered a competency evaluation for them and they've not been found competent or anything like that, the forensic flips or the civil commitments?
That's not what I meant.
Oh,
We
I'm sorry.
understand. If you say there's no civil conversions, we understand that to mean that they're not going to have appeared before a judge for a criminal act.
Right.
Okay. But people that don't have to necessarily be involved with a law enforcement person to be violent. Right, that's when their parents or their spouse or whatever can call them in. So people like that that are recognized to be violent, but haven't necessarily been within the court system, or they come into this facility.
This is here for Bracco document.
Perfect. This is what I would tell you. By the definition of the law, and you identified all kind of three ways that folks could get a civil commitment order. Danger to self, danger to others, or grave disability. And what I would say is any three of those commitment criteria could potentially have a 90 or 180-day order and could potentially come to the facility. Does that answer me?
One other quick question. You said you're not going to admit patients if you haven't got the staff. Let's assume you have a full facility, 16 patients in each building, and you lose staff, then what do you do?
The question is, if we have full facilities and we lose staff, what would we do? I think that's a fair question, and I would say, what do the hospitals who have lost staff do now? They buy
I'm asking
additional
about
staff.
I'm asking
No,
about this facility.
this is, I would argue I would offer as a healthcare professional that we think of mental health as this completely other thing that doesn't have anything to do with our health. The people who are going to be admitted to this facility are as sick as someone who I was admitted to the intensive care unit with a heart attack. Except it's not their heart that's the problem, it's their brain that is not working. This is an intensive care unit facility, and they need that stabilization. If there's not staff available, it's the responsibility of whoever gets the contract to provide that care to get that. If there's concern that there's not adequate staffing, then that's the responsibility of us and the Department of Health, whose job it is to oversee the safe operation of facilities, that they come in and evaluate that to see if in fact it is or not a safe environment to provide care.
Thank you. We have Jim next, and then Beth, and then we have Denise. Is it Nina? Denise? There you go. Okay, you have some time. All right, Jim, go ahead.
Thank you, seeing you persevering.
Okay, hold on. Can you go see your Jim? No, sorry.
Oh, geez, I thought I was chewing on the blanket.
Yeah, try that. Try that.
I know better. I think understanding that 1 in 5 folks are impacted by mental illness one way or another. I think it's important for us to remember that many of our loved ones, one of our loved ones, might be very involved in this, and this place would be there for them. It's not them who are coming here. It's us. It's us who are going to need this facility. Even whether or not you have committed a crime, but you still need to help them here. Understand these are long-term beds. They're no longer available at the state level. And this is what we've got, but there are only 150 of these long-term beds in Snohomish County. It's a real shortfall considering the need. So the importance of having this treatment capability close to home can't be overstated. With my family and friends being a very important part of the recovery from these healthcare challenges, I think you would find. My adult son was treated in one of these beds for 17 months. And I thank God that it was available. And you will too. I joined the first lady who came up here who indicated that we talked about staffing. My concern is that we do have certified and qualified behavioral health care professionals in place, when this place opens. I would ask that even in this environment of healthcare professionals leaving the workforce, that the healthcare authority do its very best to ensure that the right people are in place when these kinds of facilities open. Please.
Thanks, Jim.
Thank you.
We have Beth, and then Denise, and then Julia. Julia, your last name starts with a K. Julia, this was in your pocket. Okay, so you're third. Go ahead.
Hi, my name is Beth Bryant, and I'm a lay leader at Stanwood United Methodist Church, just across the street. And I want to read this statement from my minister, Reverend Justin White. In this debate over whether we should have a community-based residential facility in Stanwood, I am saddened by people's lack of compassion and understanding of what it means to take care of those who have mental health issues. Everyone in here knows someone who has struggled at some point with mental health. Friends, spouse, partner, parent, child. And I know the statistics tell us that the community-based residential treatment facilities save lives. Having one in Stanwood would go a long way to fill some gaps that we have in our community. Imagine if one of your loved ones had a mental health episode and needed care, and you do not know what to do. This care facility could be a lifesaver for them. As someone who has worked with various people in various states of mental illness, I know that I often wish we had more community-based facilities where people could have inpatient care that is close to their support system. Instead, hospitals and even shelters are tasked with the burden of taking care of such folks. As a Christian minister in the United Methodist, I am called to love God and to love neighbor. Loving one's neighbor does not come with a qualification for me. Jesus did not say, love your neighbor unless they suffer mental illness. What people must understand is that people who are in community-based residential treatment centers are not a danger to society at large. They can be, however, a danger to themselves. With suicide rates at an all-time high, it infuriates me that there are people who would rather hold on to fear and misconceptions about people with mental illness that allow a place of healing and recovery to become a reality in our own community. And we have one more.
Go ahead.
Okay. A community that cares for everyone is a community that governs and that grows and becomes more loving and just. A community that excludes and lives in fear of others is a community that ceases to thrive and continues to oppress others. Supporting the Snohomish County community-based treatment facility is the right, moral, and just thing to do. Don't continue to be part of the problem, be part of the solution. Just invite.
We have Denise, and then Julia, and then Linda. And get close to the microphone.
Okay, so I want to say thank you to the state for addressing this huge issue of mental health. My questions really are around the location that's been chosen. It's a very unusual location, being out in the middle of nowhere. So I have two questions that go along with that. One has to do with the traffic study that was done. It references a 35-mile-an-hour area, where it's actually a 50-mile-an-hour area, and it has two blind hills. And so as you come up and you're going to turn left to go into the facility, you're coming up out of a blind hill, going down, and if there's anybody turning left, there's a really good chance that somebody's not going to see them, and you're going to have a collision in what's already a very dangerous intersection. My other issue has to do with discharge to the streets. So in the hospitals, in other mental health hospitals, that's an absolutely acceptable discharge, that you're discharged to the streets. And I know the response is, we're going to immediately start working on discharge plans. And I applaud that, and I believe that that's actually going to be the case. But I also strongly believe that there are going to be people where there is no discharge plan. And historically, what that has meant is that they go out the door, and there's no place for them to go. The only place for them to go is potentially the one or two homes that they can see from where they leave. So how can we be assured that there isn't going to be a discharge in the street? You're asking for an exception to put this type of facility in a very unique place with no services whatsoever. And so as a result, is it fair for the community to ask that there's a commitment that there will be no discharge to the streets in that area?
Okay, so I heard two topics there. One, let's start with the last one first, so that's around discharge planning, and then maybe we can follow up on some of the traffic engineering.
No. Okay. So, we'll just try it every single time to make sure it works. I appreciate that question, and I think you're right. We will always say, because it is the right thing to do and everything we try to do, which is discharge planning starts the day that someone is admitted. And then we know that there is reality, and it's really hard to do. This is what I can say. We will be committed to helping place an individual where they want to be. That doesn't mean that we can discover housing. We are building housing right now as a state. We are doing teams that rally around and help with wraparound services and helping folks make their appointments out in the community. However, I will say this, folks still have a personal choice. And if after someone has a 90-day order and that person is stable and has any medications that they need, but that person also chooses to be discharged and does not want to have the services, and we still feel that that can be a successful discharge and that there's highlight tech to get that person services, there is still personal choice in that. And we need to help someone walk that line of realizing the importance of having a safe and secure home. And so again, it would be this consistent conversation with somebody as far as what does a district plan look like in our fourth year and our purpose. Because we're focused on smaller facilities in hopefully folks' home communities, that district plan will be more robust, because the hope again is if someone is from Stanwood, from Snohomish County, we can engage with parents, families, loved ones, friends, employers, to help with all of that wraparound service.
So I think just so that everybody here hears that there are people that choose not to participate in that, and your only alternative is going to be let them walk out the door, and it's miles before there's anything for them to do.
Amazing.
So what I would say is that there is consistent discharge planning. If someone is needing continued services, they will be given that information. They will be walked through and given all the information. I think again, there is, as Dr. Kenneth was saying, there is not an ability to give you 100% of an answer today. That there will never be someone that says, I will go to my appointment, but I really don't want you to help me find a home.
I understand. So we're asking for an exceptional location, but not an exceptional opportunity to move them to services.
Can we also make sure that I want to make sure we address the engineering, the traffic engineering, from some of our engineering folks? Is it you?
Yeah. So we've been working with the county on how to get in and out of the facility. And the current requirements it would be right out only and right in only. So there would be no left turns allowed if we were coming, it would be heading westbound on 200. So you'll either have to go north or south to get to 80th. That's the only way into the facility is coming from westbound.
So if somebody's coming from the east to the west, will there be a curb to prevent them from turning left?
Yeah, it's called a pork chop, but it channels everybody to the right.
Did you call it a pork chop?
Yeah, that's a technical term.
Okay, fair enough. Thank you. All right, we have Julia, and then we have Linda, and then we have Harvey Stackhouse.
So the comorbility of mental health and drug use is about 50%. What are you doing with 50% of people that are drug addicts? Have you talked a little closer to that? The comorbidity of mental health and drug abuse is about 50%. What are you guys doing with the 50% that are drug addicts? Because you claim to not be taking those drug addicts.
So the question is, what about the people who have co-occurring disorders with substance use disorders and mental health conditions at the same time? You were right, about 40 to 50% of people have both. Just like a mental health condition like depression, anxiety, bipolar disorder, schizophrenia is a medical condition, so too are substance use disorders. They are not willful weaknesses of people who choose to live a life of.
I understand that, but also that also brings crime. And we look, I understand that, but the drug abuse also brings crime, and this is where we live.
Drug abuse includes alcohol abuse.
Yeah.
And there is
And
alcohol.
drug driving.
Agree. And I don't know any community in the country that is without that financial themselves. That said, the treatment will be co-occurring. You can't, it would be like, I take care of families. It'd be like someone bringing in their baby who had a horrible rash. And they didn't pay attention to the parent brought in there. The bigger brother also had that same rash because the kid didn't ask me. Right? Be like, oh, I only care for you. Nothing. You have to take care of the whole person. That person is struggling from a substance use disorder, that needs to be treated as well. We can't treat one part of the brain and not the other. So the point is holistic care that treats both behavioral health conditions.
Right, but you guys said you weren't treating drug addicts.
I don't know who said that. I have not said that personally. I don't know who said that.
Are you guys, is the facility or whatever planning on paying to increase the infrastructure because it's going to affect the traffic that everybody that lives here to put in a commercial facility?
I can't speak to the
Yeah, that's it. You don't have to answer all the questions. So that's, yeah, did you want to answer?
I just wanted to clarify really quickly. I think, and again, I've been, I think, 0 for 2 trying to clarify, so please help me if I'm not clear. I think, to answer your question, this is not going to be a substance use disorder residential treatment facility. It will be able to, if somebody comes in with a mental health need and a substance use disorder, we'll be able to treat both of those, but it is not purely a substance use disorder residential treatment facility.
Okay. You'll still be treating, which brings them to our community.
I think you said yes, still true, yeah. Okay, question on the overall infrastructure improvements.
So the infrastructure will widen the road with an 8-foot shoulder, the full length of our parcel. And then we're providing the traffic. 300. And then we talked about the traffic control.
Right, and so I live on 78, which is east of 80th, would be the first street, or I live off that street, which would be the first street if you took a right onto 300 from 80th. So anybody that wants to go north, there's no north I-5 down that way. So anybody that wants to go north has to go left. So they're going to come, turn around at 76, and go back the other direction. So that's going to bring a lot of traffic to 76.
Well, so the bulk of the traffic is going to be south. So they're going to be repeat people. So they're going to basically figure out the easiest pathway to get north and south.
Right, and the easiest pathway is to turn around at 76. So everybody's going to be making U-turns there to go west on 300 and get to I-5 north. So by putting in a right turn only, you're going to affect everybody who lives on 76, is my point.
And everybody on 80th, if you're routing up 80th. So what I'm hearing is generally some overall concerns about how traffic is going to be affected.
If anybody wants to go north, they're going to have to go left on 300, which means they're going to have to come, flip around, and go the other direction around your little pork chop.
Do you have a specific question?
Yeah, how are you going to avoid that?
Well, I think the pork chop establishes the legal way if you basically you're committing a traffic violation if you drive over the pork chop.
How are people going to go north on 95 leaving the facility?
Well, I guess my understanding is 300 connect I-5.
Yeah.
If you go east on 300, you can only go south. So what if they want to go north? You can go north.
We need to do a little looking about how you do that. Sounds like there's some disagreement about how you do that. Okay.
So why are we not looking at what's happening at Smoky Point? Because there's already been many lawsuits, patients being discharged without housing, people discharged to hotels, so that's clearly not housing. Why are we looking at what is happening at Smoky Point behavioral health and trying to avoid those things. You guys are acting like you don't know what's gonna happen when we can already see what's gonna happen.
So can we compare a little bit to the work at Silver Point? We do a little comparative.
Patients have already died, all kinds of articles of patients dying because of lack of care and not receiving medications.
Dr. Lady here is to address that, this work at Smoking Point.
Do you want to go up here to the front so folks can? Your eyes on you?
I didn't want to say that point, it was scheduled.
Okay, so we're gonna get my
Can you hear me?
Yeah.
So, just to clarify, it did not work at Smoking Point, it did work at Special Hospital. And that's an evaluation treatment facility. They also, they orders occasionally. I don't know how many beds they have, but, there's a difference between an evaluation treatment facility and a long-term facility. So the evaluation treatment facilities like Smoking Point that get people off the street for an initial 120 hours or 5 business days. And then if they need additional treatment, they come in, there's a commissioner, and the doctor files a petition, there's a co-petitioner, they go to the co-commissioner, and then if they're further detained, they get another 14 days. It's after that period of time that they're eligible for the 90-day orders. So they're not coming off the street. They have 3 weeks or more of stabilization before they can be eligible to come to this kind of facility. In addition, because they're coming to an independent facility, there is a screening process. So it's not just everyone is applicable to this facility. So that might address some of the concerns around aggression that people were talking about. These kind of facilities cannot handle super aggressive individuals. So that's what, was one of the concerns. There is a screening process involved to make sure that we have the right kind of patients for this facility. Addressing the co-occurring disorder, I think there was kind of a misconception of how patients move in and out of these facilities. They are secure facilities. People just can't walk up unescorted, and the patients can't leave unescorted. So you're not going to have substances coming into and out of these facilities. One of the goals is to keep our patients safe and to keep the community safe. Okay. There is
I think that's it. Thank you. We have Linda, and then Harvey, and then we have Jim Dole. Brenda. Can you hear me? Yes.
My first question is you made a tribe, and how did you come about choosing Stanwood as the prime real estate here?
So a question about how this location was selected.
From the tribe.
From the tribe, yes.
This is the tribe.
Yeah.
All right, so thanks for restating that. Again, 2 things that come up today, right? So around that question, this is a site that complies with the code, the use complies with the code of the county for land use under conditional use permit. This was a piece of property that was available to the tribe to meet the terms of the compact. That's how the tribe arrives at selecting those parcels.
And the 2-acre tribe has no other property to this line.
Okay, and then there's a question about other options that I might know.
Yes.
Okay, so Keith, you need to talk about that, and then I just we both need it. Okay.
All right, do I need to restate the response to the first question?
Yeah, why don't you go ahead and restate?
Okay. So the property was selected by Tulalip because it complies as a use, it's a conditional use per the Snohomish County code requirements. It was a piece of, it was a parcel that was owned by the tribe and available to the terms of the compact.
There's no other property that Tulane has that they can put this facility.
There is, of course, other property the tribe owns that's the requirements test.
Okay. Okay, question number 2. Having read everything I could possibly read about healthcare and or mental, behavioral, whatever your facility wants to be, how is it that you define mental health and behavioral health? Is it all wrapped into one? And what happened to the hospital over at Smoky Point we were talking about? Well, I'm just saying, the statistics aren't good. Is that what we're to look at in the next 4 years?
Okay, so a couple questions there. One is around the,
It's state-owned, isn't it?
so one is the definition of mental health and behavioral health, and then if you could do a little more information about smoking point.
So we do, as medical professionals, provide nothing but confusing terms for you. So I will break it down. We have tried to move towards helping people understand that we can't separate parts of our body from one another. We used to have a substance use disorder system and pretend that that's the only thing someone had to deal with. We had a mental health system for people with depression or bipolar illness and said, that's all you'll ever have to need. And then we have clinical medical doctors for things that aren't those. But people don't live that way. We don't parse our problems into buckets of five, and it doesn't always work for us. Behavioral health is the rubric of all of it, whether it's a mental health condition, depression, anxiety, schizophrenia, or a substance use disorder. Both of those result in behaviors that both the person who experiences them and those around them find troubling and undesirable. And so behavioral health is a reflection of that big bucket. And because there's a lot of discrimination and stigma with those words, we use behavioral health. It's not volitional, it's not by choice. We're trying to help people understand that no one wakes up one day and says, oh, I'm gonna just rewire my brain so I'm goofy and don't behave well and can't control my thoughts. We are trying to move everybody towards accepting people for what they struggle with and supporting them.
Okay, can you talk, and also the second point was around
Smoky Point is owned by a separate private company. It is not owned by the state. They are under the licensure and certification of the Department of Health. We don't hire their doctors. She is part of the healthcare person, not Department of Health. Department of Health is separate. They have licensing and credentialing body and credentials on behalf of Medicare, the hospitals. They are owned by a private entity. We don't have responsibility for their providers or doctors. What we will have with this facility is we will own the contract that we will ask whoever administers the healthcare to sign. We don't have that for Smoky Point. We will have the ability, through the guidance of Dr. Willier and his team, to have much more deliberate control over how things are managed at that hospital. We do not have that authority and control at Smoky Point.
How will you keep these inmates safe?
so the question's about how to keep the patients.
So I heard the term, and these are patients. I have, remember, these are folks who are not knocking on the door asking to be there. They're not asking to lock in the room if they're not able to manage their emotions. They are not asking not to be able to see their family for 90 days. They are not asking to have their civil rights removed and their ability to never again taken away from them. They are there because they have an illness that requires treatment and rehabilitation. That is why they are there. They're not there because they did anything wrong. They are there because collectively we have yet to understand how to accept and live with low support and
What's going to happen if something happens? What are you going to do if alcohol breaks loose and stuff?
I don't know what that means.
You don't know what alcohol breaks loose inside the facility? Or even outside of the facility, can they get out of there?
So I think maybe you're asking about what are some safety unexpected things happening if you have management.
So as behavioral health and mental health professionals, we have training. We have training in how to interact with people whose behaviors are escalating. It's called de-escalation. The people who will be there will be trained to respond to folks whose crisis is ramping up. There is a locked facility, as Dr. Rayburn said. People can't just open the door.
A loft facility.
It's secure. People can't just decide, I'm leaving, and I'll go open the door, right? So I would ask now, could I tell you if 20 miles away in someone's house that all else not a great use there to them? No, I can't. No, it's not, but the same folks live in that house that might be in this facility. That's right.
Okay, so my last question, I guess, is what if somebody breaks out? Just hypothetically. And comes into the neighborhood.
So a hypothetical situation, if someone leaves the facility without authorization.
I just recommend that's Dr. Ramsey to join me. If you look at the reasons that people leave institutions like mental health hospitals.
I have a brother, tell me. How do you? I have a brother, mental brother, that got to leave his place in China.
So you have some personal experience.
So,
Okay.
how are we protected? As the community that's supposed to be helping this facility somehow.
Yeah, I think that's
Or
what
police.
Well, we'll give you some space to answer, I think, so go ahead, and then we're starting, and then we kind of jumped in a little bit, so go ahead. I think, what do you do if someone leaves unexpectedly?
I mean, there are notification procedures, so the facility, we have,
If you grab the microphone, thank you.
So typically, the way these facilities are set up, we have arrangements with local law enforcement or, it would be the tribe, I would assume in this case, so that they have proper notification if there is no opening. They're extremely rare, and these facilities are actually designed with multiple security measures in place to prevent someone from leaving without permission. So they might leave a sworn notice if possible, right? If they're looking for housing, that kind of thing, or to a doctor visit, they're going to be with staff. Okay, they don't leave unescorted. All right. The facility itself has multiple security measures built into it. Okay. There was another question about what happens if patients get kind of wild in there, right? What do you do? The staff are trained in de-escalation techniques. Everyone has to take them. I have to take them. Everyone does recertification, so ongoing training on how to manage people who are having behavioral crises. Okay. Part of what we talked about in earlier was about the stabilization process. So people do have a period of time where they're taking medication, getting treatment at another facility, which allows them to stabilize someone. So when we do the screening process prior to admission here, it's for ongoing treatment to help to further stabilize them, and then get them transferred back out into the community. Housing, they can work, and when he comes down the road, they had secure housing and follow up.
How do you do that?
How do we do that?
Yeah, you mentioned earlier.
So, as Dr. Waterman talked, discharge starts at the actually before they come through the door. We know where they're coming from. So oftentimes people haven't addressed where they originally came from. Okay? So we can start there. Do they have an apartment that's on hold? Is they have a case file for it? If not, we engage their local mental health agency that they're regularly enrolled with and start looking at where they're going to actually end up. And so we'll work with the case manager along the process, usually closer to discharge. But we'll work on housing, mental health follow-up, medication management. Sometimes some individuals will have what's called a less restrictive order or a conditional release where they have follow-up that's mandated by the court. And if they aren't able to follow up on it, then they come back into the hospital. So there are checks and balances on people when they leave, so they're following up on them, and then they have court calls.
Could you tell me why there's 20 plus facilities that are within an hour of Stanford aren't working for them?
So that question is around why
is this a new facility when you've got 20 plus? Here is person, behavioral health, mental health, health. What's up?
Okay, so if you didn't hear, that question is around why is there a need for additional facilities since there seems to be quite a few in the 20 plus in the region.
Thank you. We need to stand up, folks. All right.
Say it out.
Say it out. A bed is different, right? Some of those, as Dr. Wakeler talked about, might be that first 120 hours. Some might be really good in the 14 days. These, as I thank you for really reiterating that folks who are entering this facility are on 90 or up to 180 day orders of stabilization. So there are different types of beds to treat different folks kind of in their recovery journey. So what I would say is we do not have enough 90 and 180 day beds that are run through the state for this particular region in its entirety. And that's really the point that I think we are looking at is that there are different types of beds in the region, and these beds have been identified.
1874.
Yes, continuing. Question, Rick, was, is this already a done deal?
Yeah.
Thank you very much. Okay.
I don't know if that was actually a question, but Keith, you had a clarification you wanted to make to an earlier comment?
Correct. Dr. Wakeler, you stated a responding force in an emergency situation might be the tribal police department, as you referred to. It's actually, we've met with the county sheriff, a couple of staff members here, myself, and Sheriff Courtney described to us that the responding force would actually be the county sheriff's department with potential support from the city of Stanwood police, and of course, we're contracted to the sheriff's department. So just to clarify.
Great. Okay. Thank you. All right. So we have Harvey, and then Jim, and then followed by Andrea Russell. Go ahead, Harvey. Yeah, just gotta get close to the mic.
I'm going to follow what I actually submitted 6 questions today in writing to this group. Follow this thing going.
Yes.
Okay, I submitted in writing today 6 questions, but given the time constraint, I'm going to only address one that I think has been touched on already. And that is, I'd like to back up a little bit to the point where the decision is made to have this, I call them inmates because they can't leave on their own, but if you want to call them, I guess without a car or whatever you want to call it, they're put into this facility for 90 to 180 days, they're ordered here by the court. And I'm assuming this is a state court or a county court. County? Okay, so Snohomish County, a judge decides to send them there. My question is, when that court convenes to make that decision, are they aware of this patient's prior history? And I'm talking about specifically sexual predators, or people that have been identified as sexual predators. Is that taken into consideration, and do you accept patients that have a history of sexual predators?
So this question is around whether you would accept patients who have a history of sexual
misconduct.
Yeah.
What you're referring to are people who are committed under 7109. So RCW 7105 are civil commitment patients. And so RCW 7109 are those individuals who have been identified as sexually violent predators. And that's a different kind of.
Well, I'm really asking about their history.
So their history, we'll look into it.
I mean, the history, if there's a history of, I agree, if the patient you're talking about is there just for the reasons that you described. then I understand that. But that patient also has maybe a 10-year ago history of being a sexual predator. Is that taken into consideration by the court that's decided to send him to this facility?
Hard to say. So they may or may not take that into consideration. What I'm telling you is that we will not be permitting sexually violent predators under RCW 7109 to this facility. Is it possible that they have some level of sex offense?
Well, I guess what I'm driving at is the protocol for this decision to look at the patient's entire history, or are you blocking it to an incident that maybe took place that put this person off the radar?
I see what your question is. So when there's a hearing, and there's a defense attorney, and there's a prosecuting attorney. And there are some limitations as to what they can look at, but they can't bring up history. And so I can't say what exactly will be brought up in each case.
Okay, I understand what you're saying. It's not up to you to decide what the court considers in a case like that, but it's a question that I'm going to ask for Snohomish County to answer in this process, the process of deciding who's coming to this facility and who's not.
And that's a good thing. I'm afraid over my colleagues, but I will say that when we look at patients, like when I treated 14-day courses going on to 90, we do look at their history. Have they complied with treatment? That's the big one, right? Has there been progression of history, dangerousness? We do look at those kind of things. But on top of that, we're looking at, for this facility, we're making sure that they're appropriate for this facility.
The reason that's such an important question is because this facility is not out in the desert. It's in a residential area. There's a lot of families with small children in this area. So that's a very important question. And the court has decided this. You should be accountable for answering that question. And they should be consistent with it.
And that's the reason we have security measures in place. To make
Well, if you're all your security, as I understand it, is unarmed. Your security people are unarmed.
They're not.
Okay, and Wait, I thought. Okay, my last comment is if someone breaches this facility, however it happens, then those are the things that we have to worry about as citizens, as parents, as grandparents. So those questions are coming to you folks tonight. Okay?
Thanks, sir. All right, we have Jim and then Andrea, followed by Pat, O'Malley. Yeah, no question. Okay. Okay, so after, next would be Rob and Carmichael. All right, go ahead, Jim.
My name is Jim Rowland, and I work 3 days a week at the Skagit Valley Hospital inpatient unit, and also at the telecare North Sound down in Central Building. Okay, awesome. Yes. 3 mornings a week I work at the Skagit Valley Hospital psychiatric unit, and I work at the telecare North Sound unit out of Central Building. And we have court hearings that Dr. Raven was talking about. People are brought in within 5 days, they have a court hearing, and then the court decides if they should be discharged or if they should stay there for up to 14 days. This facility is a little different. People would be discharged after being inpatient. They would be more stable than they were when they were brought into the facility. I've never ever seen anyone discharged out the door, just showing them the door and closing it and then walking away. They are picked up by taxis, they're picked up by family members, they're taken to the bus station. I think it's a legitimate concern that people have about people wandering around their community. I'm just telling you, in the 5 years I've been doing this, I've never heard of anyone escaping, and I've never heard of anybody running around the neighborhood. I think if the people at the facility could maybe do a little more to explain what would happen if somebody did leave, maybe the folks would be a little more reassured. The people are not using drugs. There's no people coming and going. It's not a homeless food shelter. As far as traffic, if you were to stand outside of one of the facilities that I work at, it's remarkably calm. There's staff that come and go. It's not like a shopping mall where there's a high volume of traffic. Most of the people that are there are not there, and they don't have a vehicle there, and they stay there for several weeks. I guess I gotta wrap up. Anyway, I'm glad that you had this opportunity to ask questions, and I think if you answer some of the questions about the majors, you might persuade people.
Thank you.
We have Andrea, and then Robin, and then Tim Schmidt. Go ahead, Andrea. You gotta get closer.
All right, thank you. First of all, someone you were talking about earlier about intent. We don't intend to count these people. And for most people who live in Washington for more than a minute, know that what you intend and what actually ends up happening is usually 100% different. So I have very high concerns. My house is walking distance from this facility, and I have little kids. So with you having these people here with no armed security, I have a problem with that, because my kids should be able to play in their yard without fear of something happening. And I know you will say, well, it's very rare. I don't care how rare it is, it does happen. And there needs to be things put in place to make sure it doesn't. I also feel that we are picked because we are a small community, and let's just put it in Stanwood. There's not enough people to fight it. There's not a large community, so let's pick Stanwood. I don't think that's right. There are plenty of other places to put it where resources are available. People can have much more ability to have a life outside of it, and putting it out there where there's nothing but farmland makes absolutely zero sense. And I would like to know. And my first question is, why does the tribe need to pick this land when it is so far from where they are?
Yeah, they get their taxes.
That comes to you? Okay.
So the tribe owns the land as any property owner in the state of Washington would be, not in trust. So as a property owner in the area, they've chosen to do this with the tribe.
Why are you not talking about the fact that they're giving their taxes in exchange for giving you this land to build on?
Okay, let's hold on. We can come back with more questions for you, but
Okay.
is there?
That
Go
is
ahead.
understandable. However, they're not just building a house. They're building a mental facility without any security. If it is about the tribe, it should be on tribe land, not on this land, because we are the ones who deal with the repercussions, not them. And I know people who work at the tribe, and they do very little, especially with drug use. They do not do anything until after someone's already addicted. And I know this firsthand because I know the nurses who deal with these patients. The other thing is, I would like to know why there was not a vote before this was so-called death yes.
Yes. Okay, so Andrew, that wraps up your time, but we'll get that answered first. So the question around the decision-making process.
Yeah. No, why was there not a vote?
No, thanks.
So the process, the conditional use permit required by Snohomish County is what's being followed. And that comes to a hearing as part of that review process. There is not a vote procedure as part of that process required by the county, which we're all required to comply with.
Okay, thanks, Andrew. We have Robin, and then Tim, and then Anna. Robin, go ahead.
Well, I just would like to
You gotta
say,
get closer to it.
I'm not against the facility in any way. My question is, right now, at this moment, is this land zoned residential?
Did you hear that? That was a question around the zoning.
I'll ask Jim to back me up on this one as our planning expert, but the current zoning, I believe, Jim, is R5, and this is a allowed conditional use within the code for an R5 site.
So it's residential right this minute?
So R5 has several uses beyond residential.
what is it?
So are you trying to change the zoning to commercial zoning?
Correct me if I'm wrong here, Jim, but no, it does not change the commercial, there's a conditional use, after approved by the county.
So the one commercial.
So conditional use, so let me just back up a little bit. So this is an allowed use on the site under the Snohomish County Code. A requirement to, it is required to be, you need a conditional use permit in order to execute a project under this use on this piece of property. And as Keith said, that's the process we're going through. And so that includes an application to the county. There's a public hearing, and then a hearing examiner decides if the project meets the county requirements for this particular site.
So would that be being changed into a commercial use? The zoning, I'm talking about the zoning. I'm asking if the zoning is going to be turned into a commercial use zoning.
No, there's not a change to the zoning. This is allowed under the current zone.
It was my understanding it was being changed to commercial. It says it's not. Not at all. Okay, well, I just feel like this is a bad fit for the neighborhood. I've lived there 45 years and I just don't feel it's a good place to put it because there's too many families living there. And that's my comment. Thank you.
Thanks, Robin. We've got Tim, and then Anna, and we've got Candy Troutman? No, not Candy, okay. It's all right to withdraw, we grab the next one, so, Richard Vaughn? Okay, go ahead, Tim.
Esteemed panel, thank you for showing up, first of all, and sharing your knowledge and expertise with us. I appreciate it. I operate in a sphere where people say a lot of words, but ultimately what matters is how they're willing to find themselves, and obviously that comes a lot shorter than the words. In the worst case, if someone were to escape, it seems like it's ultimately our community which is going to suffer. So, if someone does escape, even though you've given assurances, what negative consequences are you willing to bind yourself to in that case? And let me tell you, this answer, how you bind yourself, is going to mean more to me than any words of assurance that you can provide.
Is that
Yes, here's my point. If someone, you give them security assurances, but you're not binding yourself to any negative consequences. So I'm asking you, are you willing to bind yourself if someone escapes and harms our community? What negative consequences are you willing to suffer for that?
So I don't, I'll be honest, I don't have an answer to that. I think that is a difficult and challenging question to ask for the above reason. If any of you leave here and you happen to find somebody that you don't agree with and you slug them, and I didn't say you can't go with anyone on their way home, am I responsible for that? I'm not trying to, what I know from seeing this room full of people who should care about your community, that is absolutely 1,000% clear. You wouldn't be here if you didn't care deeply about the evidence of the community and keeping it intact. I cannot stand here and say if something could happen in 2 years with someone who I don't even know will be there yet, that might happen, what would I do? I can't answer.
No, but you could be saying, for instance, I'm willing for this facility to incur a mild financial penalty, and you haven't even done that. Yeah, so if someone were to leave and harm our community, you could say, well, at least incur some financial penalty for that. You're not willing to even make that step.
I don't have the authority to.
Right, so ultimately the answer is our community suffers the harm. This facility does stop.
What I would offer is that we've heard that if there is a patient who escapes, that it is the county sheriff's department that is responsible for the response to that. That's what if there's a law, it is that county sheriff's determination as to what that law is.
Right, so your facility suffers no consequences for that escape from your supposedly secure facility. That's ultimately the answer. And that's what I want to know.
Yeah. Sure.
Actually, bring your book there.
No.
Okay, So basically, you're getting a question of liability, and you're saying, well, who's liable? 99% of the time, the court determines that. People sue, things happen. You go to McDonald's, you get a bad burger, you get sick, and you go back to McDonald's and say, I want $1 million. I got sick, I don't feel good. It doesn't work that way. It's a legal process that happens. If somebody escapes and there's negligence at the facility, and a lawsuit is filed, that is where the repercussions take place. We don't just say, if anything bad happens, we'll pay someone $1 million. It doesn't work that way.
So I understand that, but they nonetheless make the choice. We will incur these consequences if somebody escapes. They're not willing to take on any consequences. So you give words, but you're not willing to bind those words to real negative consequences.
So I don't think that's based in any kind of reality. I mean, you take a look at the ferry system, you take a look at the state hospital, you take a look at the school system, you take a look at every enterprise that the state is involved in, and you say, can bad things happen? Well, the answer is yes. Do they presuppose that and say, and when it does, we're going to pay X number of dollars, we'll remediate the situation with X procedure?
Yeah, so that's going to be a difference of opinion, because again, they give words that it's safe, but they're not willing to actually back up those words in a substantial manner.
So I think we've heard your comment, and I think that the panel isn't necessarily answering the way, you're not getting the answer that.
No, I got the answer. There's no answer. Okay. So, on to the traffic question. You mentioned how it's a right turn in, right turn out. You already have this in Stanwood and Civilian. If you're familiar with Stanwood, on the west end of Stanwood, there is a storage facility. Right turn in, right turn out. Because of this, people drive over Leak Island, up the hill to Camino Island, they make a left-hand turn, and they wear out a rut in the parking lot, making a left-hand turn. People will find a way to get in one way or another. So why do you think that this is the best solution for that location, when people are going to do obviously what's easiest?
So Tim, we'll take that question at that time. Yeah, thank you. Traffic question? Did you just say put the pork chop in? And that's fine. Okay, so pork chop is my favorite thing to do.
Yeah, I just would say that, the majority of people come to this facility are going to be staff people. And so the majority of people coming to this facility are going to be staff people. And, just like everybody else, they're going to be required to comply with the traffic laws. So I can't speak to what happens in other sites.
Keith, did you want to jump in?
Please. So it would be fair to say that the design solution is not arbitrary. It is compelled by the code and building code requirements. And that is the design solution that PCRA has delivered and is now going through permit review, including traffic study review. So there are guidelines that lead the designers to a solution and the code reviewers to basically allow us to do things or not do things within the public right of way.
Okay, we have Anna next, and then we have Richard, and my last card in there is Rick Doty. So that's our last set. And we're coming up on time, but we may be able to stay for just a couple extra minutes. Did I miss a name?
No, but I'd like to ask my name.
Okay, great. So we'll do that after. So we can stay for a couple extra minutes. So we can make sure we get through books. Yeah, go ahead. Anna.
Hi, my name is Anna Nepomuceno, and I am the Director of Public Policy for NAMI Washington, and that's NAMI, National Alliance for Mental Illness, and I came here to speak in support of this facility. This is going to be a community-based facility made and meant for people from this community. The future patients of this facility could be your neighbors, your friends, your family, people that you know and you love in your community. And these people will have an opportunity to get the care they need close to their friends and close to their support system and close to their families. Now, I acknowledge I'm not from this community. I acknowledge that, okay? But so why did I come all the way from Tacoma, Washington to speak in support of the facility? It's because I believe in the efficacy of community-based care. And I'm also here to speak on behalf of NAMI members from Snohomish County and Skagit County who have asked me to speak on their behalf. I actually have a statement from somebody from this community who chooses to remain anonymous. Sorry, it's pulling up. Okay. So her statement is, I would have been opposed to such I would have been opposed to such a facility in my neighborhood 15 years ago. It wasn't until things came full circle in my own family, with several close relatives struggling with mental health challenges and suicidal thoughts, that I changed my mind. I was fearful of what I didn't understand. I began volunteering as a mentor in several nonprofits, and that's when my shift happened. Snohomish County was in dire need of treatment facilities. I work with folks whose loved ones are jailed for months at a time, waiting for an opening in a behavioral health facility. We treat our stray pets better than this. I've learned that folks with mental health challenges are 10 times more at risk of being the victims of violence rather than the perpetrators. I am now more frightened of an angry person behind the wheel of a car than I am of a person living with mental health challenges. Thank you.
We have Richard Vaughn, and then we have Rick. Is Rick still here? Rick, okay, so you're next, and then, you have your name? Vicky. Okay, so Rick and then Vicky. Go ahead, Richard.
Okay, my name is Richard Vaughn. I live on 300, and for traffic in that area, just try to cross 300 to get to Merrill. It's almost impossible. That's a speed limit, and it's going to end up creating some problems on that corner. Other than that, my question would be, how is this going to affect the GMA lines?
Okay, the question is about how it affects the GMA lines. GMA, Growth Management Act lines. Okay, here, pass the mic here. Okay, Justin, go ahead. Oh, microphone issue. There you go.
So just to restate your question, it is, will this affect the growth management or the urban boundary area?
Yes, that's correct.
It won't.
At all?
Like the question about, is the zoning going to change? This is an allowed use as a conditional approval within the current zoning.
Okay, thank you.
Thank you. All right, we've got Rick and then Vicky. Yeah, Rick and then Vicky.
Hi. Okay, so my question is to do with the, because I'm a newcomer to this whole program, I don't know exactly who, and I understand the tribes are the owners, and you're building this facility in conjunction with the state of Washington, right?
Yes. Go ahead, Keith.
Okay, so clarity to that, the tribe owns the land, the tribe is building the building and turning it over to the state to operate.
Okay, so they have a stake in it, and I understand that, but I really have an issue. You know, I've been going through some other things. I've got tribal members in my family. I've got 2 children who are black, and so race is a deal for me, and I don't really understand why they have a stipulation here that the 2 native tribes of Washington will be given admission priority. However, the facility will not be predominantly composed of patients from the population. It seems to me like it should be, that shouldn't even be in there.
Yeah, I've never heard of a healthcare facility making any sort of statement about race and who it's
Yeah,
priority.
it should be people with what you call the mental health issues or behavioral difficulties or whatever what you call it. But this whole idea is divisive. And in this society we live in today, there's plenty of that to say, I'm this and I'm that. And I have, these people have priority and these people don't. I mean, if I got together with my old buddy Bobby and Billy, and we built the facility, and we said, well, all the people that can come to this facility, priority is going to be given to people like that looking just like you, or that have this certain skin color or something like that. That's weird in this past. You got to get over it, and that should be removed from whatever the stipulations are, the bylaws, or whatever you're doing with this. Get it out of there and make it people with behavioral problems only.
Okay, thank you.
Is there a comment about it?
Did you have a question? Do you want, you would like
I'd
my
like
thoughts?
to change.
Okay, there you go.
All right.
Why is there priority?
Keith, go ahead.
So the terms of the contract is what you were referring to. And that was, those terms were negotiated between the governor's office and how any particular term made it into that agreement. We would have to go back and talk to the parties that negotiate that. I would encourage you as a member of Washington State, a citizen of Washington State, to contact your electors. And if there's terms, because the agreement has been approved by our legislature,
Hold on a second. Go ahead and finish. Keith.
that would be a point of influence into perhaps part of that negotiation ongoing if there was a revision or a review later.
Is there a process for that to happen? Or is it something that you act upon?
So you referenced some kind of revision, I guess, or wondering whether there's a process.
Yeah, through that process, the state would have to request a consideration.
Okay. Thanks. Thank you. Vicky?
Hello. Question for you or for the panel. You said that you don't manage Smoky Point. Who do you manage? And is there a comparison, or how do you manage? Tell us your success and failures.
Okay, so a comparison facility that is under the your management.
Right, fair question. So Smoky Point is owned by a for-profit company, as I mentioned. The state operates Western and Eastern State Hospital, which, as you know, have been transitioning from facilities that take folks on long-term commitments, both civil and forensic, to hospitals that are looking at forensic commitments. The state has usually contracted with facilities for the services that are provided by the professionals at that facility. We don't typically pay or build buildings, and we haven't typically, with the exception of the facilities that house people with development related to intellectual disabilities, the state operates those as well. Separate from the state hospitals, we don't currently, in our unit, operate behavioral health facilities. So do we have a track record to share? No. What I can tell you is that I, like you, read newspapers. And as a physician, I can tell you it's not okay to turn people loose without a place to go. It's not okay to have staff that don't pay attention to people's cry for help. That's not okay. And do I have the authority to wave a wand and say it won't happen? No, I don't. But I can tell you that myself, Dr. Waterland, and all the professionals that we work with, many of whom are here today, we work for the state and we have these jobs because we care about people, we care about everything. And what I can tell you is what I will do, what I can do under my authority and my influence to assure that the care that's provided is under our purview, that it's acceptable and good. Can I be responsible for if something happens? I would be disingenuous if I told you yes. So can I promise you anything? No. Can I tell you that the integrity of folks who work for the state because they choose to? Because if you feel like a whole lot more money working for the private world, that's what I can share with you. It may not be enough, it may not be satisfying, but that's what I can share with you. I don't know if that would be Dr. Water or more.
Dr. Waterman?
And so I'm going to say it because I want to keep this on. So, what I would say is that we do currently contract for beds from healthcare authorities' point of view. While we don't operate facilities in this way right now, we do contract for beds, and we do, like right now, I think there are 6 that are part of Providence and Everett. And so we do have contractual relationships with folks for these types of beds that we can look to. And I think what we do is look at our numbers and talk about the elopements, which have not been happening. And so I do want to let you know though that we do have currently existing contracted relationships for this type of work, even though we don't have a facility that's been built like this right now. So I hope that that kind of offers a little bit of clarification in that we do like work in this realm already in Washington State.
Very small. Second question. Will you offer the local residents emergency notification like Clark County is doing?
So that's up to the local arrangements.
That's why I'm asking.
So that's something that is a good question. In the land use hearing that you'll have, in the land use hearing that you'll have time to talk about your concerns, how you like that problem information. Those things can be brought up with the commissioner if it hasn't already been worked out in the current contract. And if you have other concerns about the land use, or traffic, those are good times to bring it up. I did want to bring up around traffic. People talk about the number of cars that are coming.
Yes, and with in the proposed land use or the traffic use, it was not disclosed that there's 325 houses that are being built nearby, as well as the 430 homes that are in Lake Ketchum. That is not in the paperwork for the land use and the traffic use studies. Just wanted to that.
So the way these facilities work is they generally shift work. So people come in shifts. So it's not like you're having cars all the time, like a residential facility where people are coming in and out, or not residential facility, but residential housing. We've got people coming all day long. There's a very discrete community where the new shift comes in, you get report, the old shift leaves. And then there's nothing. We're not talking about huge numbers of cars here. Day shift is probably going to be the biggest one. We're talking maybe 20 cars. The other shifts are going to be less. It's not a huge number, and they are in a very quickly level. Around security, these facilities, I apologize that I got stuck in traffic coming north, but we designed these facilities with passive security involvement, so you have to go through multiple sets of doors. You have to use active security, so you have to use keypads that are issued by staff. There are cameras throughout the facility to monitor what's going on. So it's very difficult for someone to get in and out unnoticed. All right, and I think that's one of the concerns that it's easy to elope. You have to go through multiple sets of doors without someone stopping you or noticing. And alarms do go off. The doors have usually like a buzzer.
I appreciate what you're saying. I lived in Snohomish for some time, quite a long time, for 25 years, and 3 times in that area I had my property swept for inmates escaping from the prison. So this is not very comforting to me. It's great that this is all happening. So with that, in an attempt of an escape or the happenings of the movement, as you're saying, in the encounter that might happen with one of us in this area, you folks are trained in de-escalation. Are you going to provide de-escalation tactics training for the community? Just as if we went to CPR training or something like that, that if we came upon somebody that was needing somebody to interact with them and de-escalating somebody that needed help, somebody that was in a situation that was crying for help. How are we, as a community, going to best help somebody? Whether it's somebody that's coming from the facility or somebody who needs to be in the facility. I think that's a good question. Whether we're in downtown Seattle or we're in Stanwood, where we are encountering folks that are in a behavioral crisis, how can we empower ourselves to help others? How can we be a good community member? What I haven't heard so far in this panel, in any of the town hall meetings, in any of the interchange, is how you guys can help us help you. I haven't heard any of that. So how can that happen?
Okay, so we're at the timer, but that's a, who wants to field that question? You all want to take it? Okay, go.
So when someone looks in the facility, when they leave,
A little closer.
so when they leave, and they're not supposed to, what they're trying to do is get away.
Yeah.
You do not, so to have you interact with them and try to stop them, would you do that with anyone on the street? Would you try to, knock somebody down to the ground? No. You wouldn't do, that's unsafe.
Just hear me out. I'm just entertaining what I have to say, because I have encountered folks that I've had to use de-escalation on. So please entertain that idea.
Okay, so I would not advise you to.
Are you going to provide, is anybody going to provide training? You folks have training. Is there any type of public training of de-escalation?
Okay. We'll let you finish your statement. Yep, go ahead, and then we've got time for
So, I wouldn't advise recommendations. What I would do, if you see someone in distress, I'd put 911.
Our 911 is half an hour out at the most.
Yeah. But I've got working on it.
So what I want to say is, we, Dr. Warren and I are willing to make it excellent.
Yes,
And it's a very fair point. And how can you help us help others? That's a great question. We're happy to engage in further discussion. There's mental health first aid. The escalation trainings can be long and maybe long, and I think Dr. Raven.
This is a lifetime for us to have this here.
I understand that. I understand that. And just like the folks that were in Monroe Prison who stayed and ended up in here are very different than the folks who are going to be in this facility. That said, sometimes, and it's rare, people may leave, but they may leave because they miss their family. They may leave because they don't like being told what to do 24/7. They may leave because they just need to be outside for a variety of reasons. The likelihood that they will engage is probably not real nice. Is it zero? No, it's not. Do we want to be good partners with you and help provide your community information, and if there are skills that can help better support folks in your community who struggle, I would commit to having further conversations, and I think Dr. Waterman wants to, we want to be helpful. This is your community, right? We want to be helpful to give you tools that you feel would be a benefit to you, and what we can bring to bear for those. Our agency does training.
Okay, opportunity for follow-up. Yeah. All right, did you have one that's what you want to add?
I think just again, to echo Dr. Williams, doing pretty well without that microphone. Is we hear you, it's valid, and I think a desire to have that continued conversation of how can we have that conversation of how can you help us help you? Yes. So thank you for bringing that up. I think and it's not something that we will be able to answer in a short amount of time. And so I think it's further conversations that it's worth saying, let's figure out how.
So what I've heard though is that there is mental health first aid, which I have been through before, and I very rarely heard you say that. So I would like you to hear the community hear that from you, that is an available option.
Yeah, mental health first aid is an available option. It's somewhat equivalent to CPR for folks who are in mental health crisis. That's something that our agency has opportunity and in the future.
Great. Thank you. That is, my bowl here is empty, so I wanna check, hold on, I wanna check if there's any other cards that you've gotten. Excuse me. Any other cards that you've gotten? Nope, okay. So is there, hold on, is there anybody who hasn't spoken who wants to ask a question or make a comment?
I had a second card, but my name was Sapphire.
So right, we only did people once, so hold on a second. So we have a woman back here who hasn't had a chance. And then, we can stay till 8, so we've got a few more minutes. And so for the 3 folks who wanted to make another comment, maybe we can have you folks come back up again, but we'll start with someone who hasn't had a chance.
They're very short. Can you hear me okay?
Yeah, you just gotta get close.
They're really close.
I know, unfortunately.
Okay, so I'm hearing many answers to our questions about why this location being because we can, not because we should. And that is concerning to me as a member of the public, in particular for the patients that will be cared for in this facility. I'm not hearing anything about why this facility location was chosen for the patients that it's intended to serve. Can you tell us if that was a factor and what considerations were made on behalf of the patients for this location?
So that's selection and some of the decision factors that were considered, particularly from a patient perspective.
The environment, the environment on the site is conducive to therapy. Many of you may not know the Toledo has a facility on the site that helps some of their members act. It's no way connected to this operation of the facility. That excellent consideration of this location. And we that's
So my understanding is.
Hold on, it's your turn.
Sorry, I didn't know if there was somebody else that was part of the panel.
No, it's your turn, yeah.
So, my understanding is that the executive branch of our state's government is using patients out in western and eastern communities to provide a better outcome for them based on best practices that are in other locations. And I'm not necessarily seeing a correlation between some of that literature and this particular location, given the low population density in this area, and given the lack of public services in this area, and the low number of prescribers that are located near this particular facility. So I'm looking for a good, strong correlation between those best practices and this particular location selection. So I don't know if you have the information available today, but I think the public, I think the people that are advocating for our behaviorally ill, I'm not sure if I got these words right, you guys can change them on me. The people that need help are don't advocate for themselves often. And I know that many of you here are here because you want to serve that population effectively. And again, I'm not seeing a high correlation between the location of the facility and the care for the patients that it will be serving.
Yes.
So this is zoned R5, and I think, and I'd like for confirmation here, that means one residential home per 5 acres. Is that right?
Yeah.
Yes.
Okay, thank you. So I was looking for confirmation up here. So that typically isn't 20 vehicles coming in and out of the piece of property. And so I want to make sure that we are consistent in how we're thinking about this location, about the population that it's serving, and the community in which it is located, because we seem to be using different facts for different purposes. And that doesn't serve anyone well, neither those of us living with it, nor the people living in it.
Thank you. We have just a few moments. I have 3 people who've indicated they want to make additional comments. If you can keep those shortish so that y'all can get out. We have them until 8, but we don't want them to shut off the lights on us. But I think you had noted first, and then we've got Keith and then Linda. Okay.
Well, I will say maybe I shouldn't talk because the last speaker did such a good job of wrapping up, I think, everyone's concerns here. I would be 100% in favor of this facility if it were in a location that I thought would be more serviceable for the patients here. So we're talking about the wonderful, restful environment. They're locked up inside. Yes. We're talking about, there's no bus. The movie theater is seldom open. They're not going to be able to go anyplace anywhere. I don't know if you've ever tried to get dinner, a decent dinner in this town after 7:30, but you can't. We came here because of those things. But a lot of people don't want to live here. They want to live where there's life, where things are happening. My kids ran away from here as soon as they could. They live where there's action. We have no action. So you're going to take these people and isolate them in a secure facility, and then they're going to be okay to go out on their own. If they decide that they don't want to take residential services and they want to walk away, well, my house is a quarter of a mile away, straight down the road. And there's no way that this is a problem. We have livestock. So it's open. Anybody who wants to walk through is more than welcome to. So I do that as a quick one. So answers, yes, no. How many staff are you going to have in here?
Well, that's not a question.
Oh, okay. Give me another number of staff. How many staff?
Well, it depends on how many staff at that will depend on the census.
16 patients. How many
And
staff?
our staffing ratio is 4-to-1.
So 4 staff.
But in night people are sleeping, so that may be a 3-to-1.
So you
ratio.
don't have a 4-to-1 ratio, you have a 3-to-1 at night?
It depends on, again, how many people are there and the composition of the staff.
If you have 16 patients, how many staff members will you have on site at night?
Our model is for 4-to-1. 4 staff.
4 staff. Now, will those be trained behavioral people? So they're not going to be the janitors, they're not going to be any.
Absolutely not.
Okay. How many fire doors are there?
I would defer to
Somebody
the
should tell me.
people for the fire doors to go.
So there's 3.
There's 3. So you have 4 staff members and you have 3 fire doors. On staff at night, you told me 4 staff.
It's a 4-to-1 ratio, 4 staff per 1 patient.
No. 4 patients for 1 staff. So if you have 16 patients, you have 4 staff.
Okay, 4-to-1 the other.
Okay. And you have 3 fire doors. So there's a fire alarm. Do the fire doors unlock?
So the,
Yes or no? Do the fire doors unlock?
well, it's not a yes or no question. The doors do not unlock at the fire alarm. They unlock at sprinkler flow.
Okay.
And the staff escorts the patients out of the facility.
So you have 4 people escorting 16 people out of 3 doors. You could not be Brownie leader with those kind of numbers. Well, you're gonna, so somebody's gonna have 2 or 3 that people that they're gonna have to hang on to. Who's gonna be running through the building, knocking on all the doors to make sure everybody's out?
So clearly, the point here is just around when emergency situations and how there's safety, how safety is taken, how safety is
I guess my issue is we keep asking specific questions, and we're not getting specific answers.
So we're tight on time, so Keith, come on up.
Yes.
I don't know. Sorry about that, it's because I haven't had it before, but
Okay, I just wanted to get back to the reasons why you're here in Stanley. Keith, you said the tribe picked this site because they own the land and it's, you call it allowable use, I'll call it a use that's allowed by exclusion. Okay, they have to, it's an exception. So it's not allowed, you can't just come in here and build a behavioral health facility in an R5 zone. You have to go through a conditional use process. So, the reason why they're coming out here into the country is because of what the governor said, if I'm not mistaken, this leader, that we want people to be in their home communities so they can receive care with their family members or friends. Supposedly that helps them get well quicker. My question is then, is if we assume a uniform distribution of mentally ill within the population, the most patients are likely going to come from our population zones, Everett, Marysville, Linwood. Why isn't this facility being placed down there? Up here in the northwest corner of Snohomish County, you probably noticed there's a lot of farmland and woods. There's not a significant population up here. These people are not going to be in their home community.
That's right. And there's no sewer or water. Yes, that's right.
All right, so with respect to the property itself, you said they found it to be suitable. I take exception to that. If they had used the entire 10-acre parcel, it might be large enough for everything you have in mind. But instead, you've excised out 4.81 acres for this facility. It's not large enough for the amount of parking spots you have right now. It impinges on the wetland buffers, as does some of your, you call them patient patios. I call them exercise areas. So from that standpoint, as well as the fact that you're restricted to that size, that's why you have the traffic problems, and you can't just exit there normally either left or right. Okay. I'll just go along and say that I think the traffic study needs to be completely redone because of the 360 houses being put into the south was not considered, as well as the fact that the intersection at 76 and 300 was not examined at all. And all outgoing traffic is going to now be passing over 76th. So,
thank you. Are y'all willing to stay for more?
Yeah.
Okay. And I think we're hitting the end of our time, but you get the last word. But keep it up.
Okay. Why couldn't we implement a text alert system if somebody was to alert? We should put our numbers on the list and be alerted. We have a lot of land out here. If somebody's on our land, north of 300 is all mostly 5-acre properties. If people come into our land or our woods or our farms, we should know that somebody's coming. Or possibly coming.
So a question about a potential text alert system.
Or siren.
Or some kind of alert. Dr. Watterson?
Thank you. So I know that statutorily speaking, there are, and somebody did a comparison last week. Sorry.
Hold on a second. Okay. Go ahead.
No, I mean,
No, I think people were just having some conversation.
Go ahead. Yeah. Somebody asked, kind of down in Clark, right, if we were gonna do the same sort of notification, I think it came out of the hearing, and so statutorily, there's a difference down in Clark, and part of the reason why that decision was made is that those individuals are from the civil conversion population. This is civil commitment, and I know that that doesn't sound satisfying for me to tell you. There is a difference in notification around the texting and notifying prosecutors in that civil conversion population that's different than the population that will be at this facility. And so we cannot guarantee, because we don't have the law behind us around that same kind of text notification. So I think, Brian, what you were talking about, or Dr. Wayne, or sorry, is that would be up to the hearings examiner that was go through that process.
We all live out in the country, we all have guns. If somebody gets into our house and there's guns everywhere, it's gonna be all out, it could be anything. Because we have AR-15, we have guns, we shoot on our property, and they're all over the place. So if somebody gets out and wants to hold a gun, it won't be hard.
And so the response that you had is that might be something to pursue through your house. Okay. All right. Okay, so how are we doing on time? We're getting to the end of our allotted time here. I do see one gentleman. Did you have a chance to speak yet? Okay, so we're gonna go, you have not had a chance to speak yet? So come on up, you can make a comment.
I'm good right here.
Okay.
Just got one question. What is in this for the two ladies? I am sure they're not going to
tax money.
their heart.
Okay.
I am sure that this is she will say for profit.
Okay, so the question for you, Keith, is there a benefit for the Galena tribe out of this facility?
So, per the compact, yes, there is sales tax sharing. It's a settlement described in the compact that refers back to the discussion between the state and tribe has been going on for years. And this compact resolves that discussion and creates that sales tax sharing arrangement.
Not answering my question.
Okay, so we're at the end of our time. If you have a question that you did not get answered, you can write them down, right, and submit those in, and I think the team will follow up as they are able. We appreciate the time that you've spent. I'm hoping that some of you were able to get some of your questions answered, and appreciate the respectful dialogue. So thank you all for your time, and we will close out here and wish you all a good evening and safe travel. Thank you.